So thank you everybody for being here. My name is Megan Hansen. For those of you that have not met me before, I am the co-founder and executive director of Recurrent Pregnancy Loss Association. Recurrent Pregnancy Loss Association, or RPLA, as we call ourselves, is a nonprofit organization that is dedicated to eliminating recurrent pregnancy loss. We do that by advancing research into this space to try to identify what causes RPL, how it can be more effectively treated. We also provide support to the community of families that have been impacted by this. And we do a lot of work to increase awareness about the impact of miscarriage, recurrent miscarriage, and fertility challenges generally on individuals and families. That's enough about me. Today, more importantly, I have the great pleasure of talking to two of the experts that are associated with the organization. So Dr. Ruth Lathi, who is one of our medical advisors, is a professor of obstetrics and gynecology, the Division Director of Reproductive Endocrinology and Infertility, and the Director of the Multidisciplinary Recurrent Pregnancy Loss Program at Stanford University. She has a special interest in treating recurrent pregnancy loss, the role of pre-implantation genetic diagnosis in the treatment of reproductive disorders, the prognostic value and utility of genetic testing of miscarriage tissues, and long-term outcomes of fertility treatments. She is currently the principal investigator of a multi-site NIH-funded study to investigate genetic, environmental, and systemic causes of loss, where she and her team are searching for causes of unexplained recurrent pregnancy loss. She is also, incidentally, one of the authors of the new guidance that we're going to be discussing this afternoon. So it's really a wonderful treat to have her here. Our other expert is Dr. Micaela Stevenson Wyszewianski. She is on our board of directors and is the director of patient and provider education for RPLA. Dr. Wyszewianski just completed or is completing this Friday her residency program in obstetrics and gynecology at the Medical College of Wisconsin, and she will be starting a reproductive endocrinology and infertility fellowship at University of North Carolina this summer. She has a strong research interest in recurrent pregnancy loss, and in addition to her medical degree, has experience in nonprofit work, as well as political and community organizing for increased access to reproductive health care. So I'm super happy to have them both with me tonight. Before I allow them to introduce themselves more thoroughly, I want to just do a couple of quick housekeeping items. I like to call us the RPL community members, RPL families, but sometimes for the purposes of discussion around medical things, I refer to us as patients. So just know that I don't like to think of us as patients because I don't like to think of us as our diagnosis, but I may use patients just for ease of conversation. And with that, I will move this right along. Dr. Lathi, Dr. Wyszewianski, can you both introduce yourself a little bit more fully and tell us what you're looking forward to in tonight's discussion?
All right. I guess I'll go first. Ruth Lathi, I'm at Stanford Fertility and have been really dedicated to try to help get these guidelines to the finish line. It was a incredible laborious process, but really excited to see them coming out. It feels already that there has been an impact on patient care, and that's the goal of this work. It's an honor to be here with Megan and all the incredible advocacy work that she has done, as well as Dr. Stevenson, who was just a rising star in this field. So it's going to be an exciting conversation today. I'm excited to be here and really looking forward to see how these guidelines and our discussion today can help people who are out there trying to start their families.
And I am Micaela Stevenson Wyszewianski. I'm currently at the Medical College of Wisconsin, finishing residency in OBGYN. I'm really excited to talk about the perspective of a generalist and like in general OBGYN and how you all are able to really connect with your general OBGYN and uptake of these guidelines. I am so excited to be here with Dr. Lathi. She has always been an exceptional mentor to me. And so I'm also just happy to hear what she has to say about these guidelines. And it's so exciting to see that this has really moved forward and that these guidelines are available to help patients.
Awesome. Um, Before we talk about the guidelines specifically, Dr. Lathi, can you explain how are guidelines created? Like, what is the purpose of professional medical societies creating guidelines for anything, really? And how are they actually written and formed?
Well, I would say the overarching plan is to ensure or is to assist practicing providers to perform or to provide the highest quality of care to all and to standardize that knowledge across the country and really the world in cases like RPL, where the ASRM, where the guidelines are often looked at beyond just the continental and US. So the purpose is really to try to um, help provide concrete, actionable guidelines that really anyone can follow in the while taking care of patients who are going through miscarriages or whatever the diagnosis of the guideline is. The process for me, this is the first one I've been really significantly involved in, is that the ASRM does a review of topics that are needed to be updated. They look for experts in the field. And so the process starts with about 5 to 10 identified clinically practicing experts in the field. So it is a clinical guideline for the most part. So they wanted practicing providers, mostly doctors in this case, who have an experience with recurrent pregnancy loss in their practice. So we started with a group of 5 or 6 of us, and it grew a little bit throughout the process as we really were trying to pull in experts in each of the different facets of the document. We first started by looking at the existing document, and the last time this ASRM published a guideline was in 2012. So this is a 14-year-old document. And now knowing it takes 3 years to write, 15 or 16-year-old document that really was in desperate need of updating. So we looked at the gaps in the current guidelines, the changes in clinical practice. We all looked internally about what we were excited about and what we thought were important areas to look at, and really brainstormed, in terms of what could we do to improve these guidelines. Divide up different aspects, deep dive into the literature, examining not only the existing literature, the quality of the literature, any controversies or discrepancies in the literature. If one study shows A and the other study shows B, really trying to figure out how those studies are different and which ones are the most applicable to the question we're trying to answer. And then coming up with some general recommendations and guidelines, what needs to stay, what needs to change, what needs to be added, what needs to be removed. And then that process itself took well over a year, probably 18 months of really, volunteers who are also practicing at the same time and working with the ASRM Practice Committee Guidelines Committee, who then reviewed our first draft, gave back, I don't know, several dozen nuggets of feedback that we had to go reinvestigate and kind of reiterate the words that were used, and then back and forth a few times at that level, then to the ASRM board, another round of input from people with different experiences and understanding of the literature, and really just wanting to come up with the best consensus guideline across experts, across practicing REIs, across the board, and then back and forth through each of those different organizations. And then ultimately led to the guideline that you're seeing today. And it really is a lot of work goes into these, and a lot of thought, a lot of discussion back and forth.
No, thank you. I think that's really helpful. I mean, we've all been in meetings where like coming to consensus on anything is so difficult, and coming to consensus on this, I imagine the stakes are so high. So
Yeah.
I appreciate that explanation of all the kind of work and opinion and iteration that went into this. I'm going to share again a slide here. And give me just a second. Uh, so the biggest kind of change that I noticed, and I think everybody noticed kind of reading through the new guidelines, is this shift from, I don't know, specific recommendations of like, this is what you test for recurrent pregnancy loss to more of an evaluation algorithm. So I wanted to just start here and let you explain why this kind of stepwise process is more appropriate in 2026.
Yeah, I think that I spent, I don't know, a decade of my life trying to convince people that when a miscarriage occurs, that we should look at the miscarriage itself first before looking at the parents or the pregnant people. Um, we know that the most common cause of miscarriage lies there. So, in our quest to provide more answers to more patients, this single test will provide answers to more patients than any other test that we can provide. That test, the response to that, or the results of that test will inform if any additional testing is needed. So that was how we were thinking about trying to really put the focus on the miscarriage itself, and then only on the parents if we couldn't find the answer there, because that would help guide things. In my practice, and I'm sure in most providers in this field, we really want to find answers, but also remind our patients that the focus is not, the cause is not within them always. It's often in the miscarriage or the pregnancy itself. So it helps us to realize that embryo problems are the number one cause and really should be central to the evaluation.
Yeah. And then, still looking at this slide, another thing that this points out is that the definition of recurrent pregnancy loss changed from the 2012 guidelines. It was 3 losses. So can you talk about that shift of why now 2 or more, and the fact that they don't need to be consecutive, and the fact that biochemical pregnancies, I don't like the term biochemical pregnancy, I tend not to use it, but those are all included in the definition at this point. So can you talk about why that changed a little bit?
A few reasons why that changed. One is that we want to put the patients at the center. We are treating our patients or the people coming to our office who want to have a baby, and their experience, their concerns should be met with a response, right? What should we do? This person is concerned. They want to understand better. They want answers, and so we're kind of meeting the patients where they are and what they want to do. It's not necessarily that we expect to find something or that these patients are at poor prognosis, but we're really meeting the patients where they are. If a patient comes to me or Dr. Stevenson, then she would also be looking for questions, and we want answers, and so we want to meet her where she is, and that's why we did that. And I think that the first step being the miscarriage testing, even if it's only your second loss, only is not a fair word to put out there. But really honoring every miscarriage. I believe every miscarriage should be evaluated, and even 2 or more in some ways feels like too long to wait. So that's where that came to that.
I agree. And for anybody listening, just because this says a recommendation of testing for your second, you can absolutely, as a person seeing your doctor, request to have a first loss tested. So, um, the last piece in this, to either or both of you, the last piece that is like very apparent in this figure when I look at it is big, bold blue or purple text down at the bottom, which recognizes the need for psychological support and just kind of overall awareness of preconception health. So I wanted to ask about both of those things, and I assume it was intentional to have that in like big, bold purple text.
Yeah. Yeah, we really feel that this is an essential component of all miscarriage care. That taking care of our patients, providing that support, providing answers wherever we can is important. But even if we don't find an answer or we do find an answer, there is a lot of power in preconception counseling, health optimization of both partners. And this is something really any provider can do, that we want to make sure preconception, your nutrition is optimized, you're taking your prenatal vitamins, you're avoiding unnecessary toxic exposures to tobacco or marijuana, that you're, if you have a health problem, diabetes or thyroid disease, that those are controlled. Those are present in more patients than we realize. And what, I don't know, opportunity, but certainly a responsibility at that point to take a time out and say, is there anything we can do after a miscarriage to help this person physically or emotionally prepare for the next pregnancy? And this is really where I think all doctors and frontline clinicians can really step in and help us. We don't need a fertility specialist to do that. And I think that, that's why we, are really trying to share these guidelines broadly amongst all providers. And I don't know, what do you think, Micaela, about how it impacts a generalist?
Yeah, exactly.
I think this is actually really awesome because I think that this clearly outlines what generalists should be doing. I think that many generalists, in my experience, are very confused about how you work up RPL, and this makes it incredibly clear on like what you should do next is test the tissue, and then depending on your tissue findings, then you can decide what additional testing. And this testing that's available, much of it is very accessible to generalists to be able to order without so many problems. Um, I'm really excited about this, honestly, because like a uterine cavity evaluation is something that a generalist can certainly do. And also like a TSH is definitely something that a generalist can order. And then also focusing on the fact that preconception counseling is necessary for these patients, I think is a really important factor. A lot of the patients who I've seen in clinic, who I just kind of like found out had recurrent pregnancy loss by looking at their history, were diabetic and we just didn't know, or did have hypothyroidism and we just hadn't tested. And this can be a really wonderful opportunity to screen people for when they do go on to have a pregnancy, that we're really optimizing their health prior to them becoming pregnant, knowing that they could have some complications associated with uncontrolled diabetes or poorly controlled hypothyroidism.
Thank you.
And then Megan, to answer your other question about including um, those very early losses, we felt that there were so many disparities in miscarriage care and access to care in the first 6 to 8 weeks of pregnancy that yes, biochemical or like preclinical losses should be included, but we really wanted to acknowledge that we don't actually know when all of these miscarriages are happening. People will miss their periods and think they're 5 or 6 weeks along, have heavy bleeding, or go to the ER. No one really documented anything about the pregnancy. So we really think it's one, it's a continuum. Two, it's back to the patient experience. If that experience was a miscarriage for her, then that is what it was for me too. And so not really qualifying one as, better or worse than the other. And again, back to seeing the patient where she is and really trying to get to help that particular individual through the diagnosis, understand what's happening, what can be done, what should be done, and helping her or that family get to their goals.
Yeah. A couple additional questions, and I'm gonna flip to the next slide. When it comes to the testing, and pregnancy tissue testing, can you either one of you talk a little bit more about what type of pregnancy tissue testing we're talking about, and particularly in the case that you are needing to request it of your physician if they're not offering it, or you had your loss at home and you collected a sample and brought it in, like what needs to be requested or what type of test?
Yeah, I think that this is an area of a really important area, that there are a number of different ways you could do chromosome testing on miscarriages. the quote unquote karyotype, which is the standard or the old school way of testing 24 chromosomes, has its limitations in terms of requiring viable live tissue that grows in a culture, that is manually examined under a special stain and microscope, and requires a lot of technical expertise. And often miscarriage tissue will fail to grow in that environment, or have maternal cells or blood cells from the uterus that contaminate or mixed with that. And if a normal result comes, we don't know if it is from the uterus cells or from the miscarriage itself. So standard karyotyping, although is a good test, it has its limitations. The microarray testing, which can be done, there are a number of commercial labs that do it. They have at-home kits. They don't require culture. So these are like they extract DNA from the tissue and examine 24 chromosomes. They have a slightly higher sensitivity. They don't require cells to grow in a laboratory, and they can differentiate maternal or uterine cells from miscarriage cells. So those are the benefits, but they're not this type of testing is not necessarily available in every hospital setting or every clinical setting. So any test is better than no test, but just knowing the limitations of each of the different testing types is really important. The at-home collection kits are generally these microarray based tests that are through more commercial labs versus the hospital labs themselves. So I think that patients can do their own research on what's available to them, but there are a number of companies that do offer that, and they'll ship a kit to your house and that kind of thing. So I think that I don't know if we want to endorse a particular company or not in this webinar, but a number of companies do have that option, and the cost to patient is also much lower. So that's our preferred testing. However, if you're in a hospital and they send it off for a karyotype, that's still a better test than no test, and it just has a little bit higher failure rate or contamination rate.
Yeah. And we had a question come into the chat specific to testing. So I'm going to ask this. Is it ever possible that even if you have a DNC and it's done in a surgical setting, is it possible that a test can't be completed with that type of a collection? And when and why would that happen?
So in the hospital setting, the tissue often would be put in a chemical called formalin or formaldehyde to fix and preserve it for looking at it under a slide to look for pathology test differences. Traditionally, that once it hits formaldehyde, it no longer has viable cells. That kills the cells as well. So you can't take it out of the formaldehyde and then grow it in a culture. Most of our commercial companies will actually be able to get you a chromosome result on your paraffin block or on your miscarriage tissue that was frozen or preserved in a hospital laboratory. And actually, for those patients who are really grappling with wanting answers, we can do that for patients. If you had a miscarriage or a demise in a hospital and chromosomes were not sent, but tissue was examined or preserved in pathology, very, very often we can work with these laboratories and get the test after the fact. And many of my patients have found that to be very helpful.
My experience has been that there have been times when people have done a DNC and they have not been able to get tissue, and they're wondering why. And sometimes it's that you come in after a miscarriage and all the tissue has passed already, and what looks like there's still tissue in the uterus is actually just blood clot. And so sometimes there is not always tissue left over. So that could be a potential reason why you would have had the DNC after most of the tissue is gone, but we need to remove some additional clot to help bleeding stop, that we may not be able to fully test that tissue.
Yeah, that's true. If there's a minimal amount of tissue, then maybe it wouldn't have been able to be tested. I think that you want to be at a facility that's used to sorting through that tissue as well, because there are so many maternal tissues that come out. You really have to look and rinse the tissue to look for finding that right tissue to send. So we really encourage, that's one of my points when I go to ACOG or other places. This is how you can get the most out of your miscarriage tissue. the doctor or the surgeon has to actually look at the tissue and separate out which goes to the pathology lab, which goes to genetics, and whenever possible, just manually rinse off those uterine cells and blood cells so that you can optimize for that. But often the miscarriage tissue is a mix of cells from the uterus and cells from the pregnancy. And the earlier it is, the smaller the ratio of the pregnancy cells that are there.
Thank you. I appreciate that. I'm going to move forward onto sort of what is, I mean, this is kind of a reiteration of the algorithm, but just in bullet point form. So maybe can we kind of take each one of these, and I'm not going to ask about the kind of the evaluation portion, but I'm curious for each of these, the kind of what happens next. So the guidelines say if, following a uterine cavity evaluation, a number of things could be found, but then it says that, it is reasonable to treat surgically, but not necessary to treat surgically. So specifically for uterine cavity, things that are found, polyps, fibroids, septums, what can you talk about when surgery may be an appropriate option versus when it maybe isn't required? Either one of you can take that.
Yeah, I think, and then we can see what our rationale or our thinking around that is we're always looking at pros and cons. What are the risks of doing surgery versus the advantages of doing surgery? And so I think it was really just a balancing act for us. We do a lot of office hysteroscopy. If you're there anyway, pulling that polyp out, minimal additional risk. The reason we said it's reasonable is that we don't have really good evidence to support that taking a polyp out is going to change it, but it is just such a low risk procedure that we can easily perform in the office. But I definitely have seen a polyp or had a concern about a patient recommended surgery and she got pregnant before I could get to the surgery and everything was fine, which is why we kind of have to be humble about it, right? Like we're looking for answers, but everything we see isn't always the answer, right? So that's where we kind of have to have a shared decision. How invasive, how accessible, what is the cost of that procedure, and how sure are we that that pathology we're seeing is the cause of the loss? So for some individuals, they might not have the means to do a surgical procedure. And then we have to say, well, then it is actually reasonable not to do it. On the other hand, we're, especially in fertility, we're kind of a little bit obsessive about wanting everything to be perfect. But so we see it, we can take care of it easily. We often will recommend that because we see it. So the data just isn't there to prove benefit. And so we have to be cautious in these guidelines of when we recommend something, we have to have data that test or that treatment, which has costs and delays next pregnancy and has a risk to a patient, is it really beneficial to her? And if we don't have that evidence, we have to be clear about that because we don't want to say things that are not proven.
Yeah, I would agree with all of that. I think that the other thing to think about is, even if a pregnancy does take, some of the times, like resection of certain things can improve obstetric outcomes. Large fibroids can contribute to malpresentation when it's time to deliver a baby. And so let's say you do get to term, we don't want to have to do other surgical interventions that we may not have needed to do if we corrected the cavity. And so just considering how this may contribute to obstetric risk in the future, even if it does progress to a live birth.
Helpful. And on the thyroid piece, I also had a question. And for anyone watching, Dr. Wyszewianski actually did a whole Ask the Expert section specifically on thyroid. So I'm not going to dive real deep. I encourage you to all go back and watch that on our Instagram feed. But the one question I just at a high level is, that was a kind of a difference. The 2012 guidelines sort of seemed like it was going to be, okay, we're going to treat subclinical hypothyroidism. And now it's a little bit more like, nope, treat overt hypothyroidism. and that's good enough. So can you talk a little bit about that piece?
Yeah, this is a really good example of where we thought we were helping people, but then, higher quality, good studies came out showing that we weren't helping people. And so again, the thyroid testing, if anyone's ever been through this, if you have a slightly off TSH, then you have to stop, take more medicine, retest, adjust your medicine. So you're delaying treatments for, months to try to get this under control, which is reasonable if it actually has a benefit. But if we now know that those people who waited 3 to 6 months to optimize their thyroid to kind of a really tight control, they don't do any better than people who are just, as long as you're in the normal range, you're going to have the same outcome. So why are we going through all of that? We're adding delays, we're adding costs, we're adding anxiety, where we're trying to get to a certain level of perfection that isn't needed. And for some patients, that creates significant delays and anxiety. And so we don't want to do that either, even if it's a cheap, low cost procedure. So we went with the evidence on this, that there are a number of high quality what we call randomized controlled trials in the field of recurrent pregnancy loss with borderline TSHs plus and thyroid antibodies, plus or minus thyroid antibodies. And we found that those who were treated did not do better than those who were just maintained per standards. So that was a good evidence for us to take that guidance off or to loosen it a little bit.
And that really mirrors a lot of the obstetrics data as well, that a person who has subclinical hypothyroidism with or without these antibodies, if they don't have true overt hypothyroidism, they don't have increased risk to their offspring. And so it's nice that now there's like a really uniform piece of information that it doesn't improve your chances of live birth. And even if you're like concerned that you have this, we don't need to treat it. It doesn't mean anything for a baby in the future.
Mhm. One question that was submitted beforehand is how does this change at all? If you have been diagnosed, you know that you have an autoimmune thyroid condition already. How should you think about that in the context of RPL?
Right. Once diagnosed with overt hypothyroidism, we know that those with high antibody titers are going to have more fluctuations. So they just need to be monitored more closely. And pregnancy itself can be a trigger for a thyroid storm or a thyroid flare of your antibodies. So we see that in patients who have repeated pregnancy and pregnancy losses, that their thyroid control will go up and down a lot. And that is usually a sign of the thyroid antibodies. When you have a miscarriage or a pregnancy loss, your immune system changes in reaction to that. And then the thyroid can, get too low or too high and takes a little longer to stabilize those particular individuals. So we know that the high antibody and clinically diagnosed thyroid patients may have a little harder time getting that control immediately after a pregnancy, and they just need to be followed more closely. And sometimes we use our experts in endocrinology to help us with that dosing. But just knowing that that is actually quite common for patients with high antibodies takes that mystery and that stress out of it. So again, what we're trying to do is meet the patient where they are. You have this problem, thyroid antibodies. That means that it might take you longer to normalize your thyroid after than somebody who doesn't have these antibodies. Then at least a patient has an explanation. Why is this so hard, right? It's most of us can deal with hard things if we understand what we have to deal with, right? It's really that unknown of why is this happening to me, or why is this so hard thing that is difficult. So I think that, unfortunately, those there are some people who are trying to get pregnant who have a harder time keeping under control, and that's usually those autoantibody patients. But we work closely with our endocrine team, and honestly, just waiting a few months for the hormones to stabilize is often the best cure.
Um, Those two, the uterine cavity evaluation, thyroid testing, recommended for everybody, regardless of sort of the results of the miscarriage tissue testing. And this is where sort of the step-down algorithm takes place. So and I'm going to ask for brief answers because I know we want to get to some of the well, what happens if all of this is normal? But can you talk quickly about when and why people should have parental karyotyping done, and also talk a little bit about the antiphospholipid syndrome, because particularly the high false positive rate, because I think I think that's actually what happened to me. I recently asked them to run the panel again. It was totally negative, and yet during my losses, I was getting, positive titers. So can you talk about both of those pieces a little bit?
The phospholipid. Yeah,
Yeah.
so again, one of the things, I guess I didn't put that in our description of how these came, is we are looking at other societal recommendations around these diagnoses that are shared with rheumatology and hematology. They came out with some new guidelines around phospholipid syndrome. And again, what we want to first do is not create unnecessary harm or anxiety or panic and chasing a test that's not clinically significant. So phospholipid syndrome is a very specific diagnosis that happens to have antibodies, right? That's one of the features, but not the only thing that makes a diagnosis. And with phospholipid testing, similar to the thyroid, if we're chasing a number, then for phospholipid testing, that's a 12-week delay before you can get a definitive diagnosis. Or we're treating based on weak evidence or a test that hasn't been validated. So we do see a high rate of false positives of antiphospholipid antibodies, and that rate of false positive really is related to two things: how high is the titer and how many antibodies are positive. So if it's an isolated antibody and it's kind of in the low or moderate range, very likely on repeat it's going to be normal. And if it's normal, then you don't need the blood thinners and the heightened anxiety around, giving yourself shots throughout your entire pregnancy. And that delay of 12 weeks for many people feels like a really long time to wait. And that could be increasing anxiety and depression and, we're getting older and all of those things that are working against us for something that has no benefit for us. And so that is what we're always trying to balance. We don't want to be chasing things that aren't helping, because that adds cost, time, energy, emotions, and for better or for worse, takes our focus away from the real problem, which in over half the cases is aneuploidy and chromosome problems and a miscarriage. And so I think that's where that came up, that I did a lot of learning through writing this guideline and really trying to understand, the thyroid antibodies and the phospholipid antibodies are a little bit of the same thing. Just because you have the antibody doesn't mean you have the end organ impact, right? So you could have an antibody and a normal thyroid and you're good to go. But if you have an antibody and an abnormal thyroid, that's where you have to really worry about it, right? So if you have phospholipid antibodies and clots and these skin or liver findings, then now I have a real pathology I'm trying to get at that could be explained by these antibodies. But it is a very serious diagnosis to have that does require lifelong management throughout pregnancy with blood thinners, and 6 to 8 weeks postpartum. So you're really committing somebody to almost a year of anticoagulation, which has an impact on our bones, has an impact on our symptoms. We're bruising, we're having other symptoms. It could impact delivery management and other things. So we know that our patients can do hard things. If we tell them they need to do it, they'll do it because they're in it with us. But we also don't want to put a huge burden like that on someone without proof of benefit. So we're always just trying to balance that. It's so easy to go down a rabbit hole with some of these tests that have a high false positive. They estimate that phospholipid antibodies are present in about 5 to 10% of the general population. And that's going to overlap with 5 to 10% of our pregnancy loss patients. So we really need to sort out which patients need the test and which cases the tests are truly indicating there's a pathology or a real syndrome underlying.
Mhm.
So we really pulled back on that, and I in my practice have really pulled back on it because I've seen the impact of these delays and these anxieties, and then the repeat's normal. and you don't believe your repeat. And now we're like, can I just do one more repeat so I can break the tie? I was like, it's not a tie, but it feels like a tie to the person who's going through it. So then we wait even longer, and we did all of that waiting just to go back to we didn't need the test in the first place. So I really like to focus in on the really strong evidence we have that in patients who have explained losses known by aneuploidy and don't have serious systemic problems with their thyroid or their diabetes, they really need a minimum. We need to check, this a uterus okay? Is there any underlying health condition that could be optimized? And then we go forward and we give that support people need as they're going through facing another pregnancy after loss.
Yeah. I think that's a good point. And it brings me to, the document actually says in there that even if you did zero treatment, that the chances that the next pregnancy will be successful is 50 to 80%, with doing nothing. Like,
yeah, I didn't
yeah.
even, yeah. But we need to support people to have that courage. And I think that really is difficult with,
no, for
and
sure.
that's why that supportive care, that psychological support, we're in it with you. We're answering your questions. We are counseling. We're not walking away and saying, oh, just try again. It's probably meant to be. That's not helpful, right? That just increases the anxiety. So be there for them, listen, help, answer questions, do what you can. There's always something you can do.
Yeah. I'm gonna close the slides and the rest will just for those of you that are, watching, I can send out the all of the slides after. But I think it's easier for the rest of this to just kind of talk to it and answer questions. I'm gonna start with, like, can we tier this a little bit? So, those things that were in the treatment algorithm, you do them. Your thyroid's great, your uterine cavity is perfect, you don't have any chromosome, like, you don't have a translocation, and you don't have APS, and you are still continuing to lose pregnancies. Either you're continuing to lose pregnancies and they're aneuploid and you just start continuing to lose, or you're losing them and they're euploid and you don't know why. What happens next? What do those people do?
Yes. I think the simple answer is that if you are fortunate enough to have a doctor who did everything on that list, I think you are already ahead of the game for most people. So if we can get that document, if we get everyone to experience that level of care, we will have really solved a lot of problems for a lot of people. But you're right, there's still a lot of unanswered questions that the guideline really, is still a subset of patients with repeated losses that don't have explanations. And so that is back to, expert opinion and, practice. Individualized care is what I do. I really try to look at each patient. How old is she? How many losses has she had? What treatments has she tried? What's her BMI, right? Does she have a history of a prior live birth? So looking for other potential clues to things that potentially could be contributing. So for our high BMI patients who have a family history of diabetes or pre-diabetes in themselves, we look for insulin resistance, and then we potentially treat that. I think that's underdiagnosed and treated. Optimizing that preconception period is really essential. Nutrition obviously is important. Psychological support is important. For patients at or over age 40 who are having losses, especially if they are proven aneuploid, there is a role for IVF and genetic testing of embryos, because after age 40, the risk of aneuploid loss just goes up so significantly that even if you've optimized everything else, your miscarriages moving forward have a high risk of being aneuploidy. And we did a study showing like about 80% of losses, even in the recurrent loss population after age 40, are going to be chromosome abnormalities. So if I want to reduce the number one cause of loss, IVF has its role in those patients. Between 35 and 40, it's somewhat questionable, but I think that that's an individualized discussion that we have with people. For those with repeated euploid losses, that's a tricky one. That's where we have consider these options. So consider endometriosis testing and treating a dysbiosis of the uterus lining. Consider DNA fragmentation and optimizing sperm health. consider some of these other things on the list, the metformin, like I mentioned, for patients with risk 4. So there's a consider list that I kind of put at my second tier. And then an even smaller percentage of our patients who fall through that, right? So we're trying to get as many as we can. The first swipe is this document. I do believe we will solve about 80% of loss with this document alone, but that 20% is where we really need specialized care, individualized care, more research into what is causing that small percentage of our patients to still be having losses despite, all the advances we already have there.
Dr. Wyszewianski, I have a question for you on the preconception care and some of these pieces too. And maybe Dr. Lathi, this will come back to you as well. But like one of the pieces that was not that was in the not recommended currently for RPL treatment was around endometriosis and adenomyosis. And I know that, that's getting a lot of attention because it's also dramatically underdiagnosed. So how are you seeing that, Dr. Wyszewianski, in sort of like your population and people thinking about getting pregnant in the future? And then Dr. Lathi, like if you have a patient that has endometriosis or adenomyosis and they're having RPL, how do you handle that? And why isn't that kind of included in the algorithm?
Yeah, I think for me, like the biggest thing that I've noticed in like the patient population that I've worked with, which is very different from like the rest of the country in a lot of ways, is that a lot of people think that like what they're experiencing is normal. So I think that with endometriosis pain and with adenomyosis pain, many of these patients have always had painful periods, or they've always had some problem associated with their periods. And that because it's chronic, they think that this is just how they feel. And that because it only happens a few times a month, that it's okay and that they can kind of get through it, or that they feel that it's very normal for them to like miss a day or two of work. And I'm having to share with them that that's like not actually what the majority of the population is experiencing. And so I think telling patients, like having really a lot of this starts with like basic health education for the patient, like what does a normal period look like for most people? When would it be concerning for you to have pain with periods or heavy bleeding, or what would heavy bleeding look like? If somebody tells me that with every single period they go through an entire pack of pads, that's like 64, which I have heard that more than once, that's not normal. That's not normal bleeding. Or if somebody's requiring blood transfusions, that's also not normal bleeding. And so some baseline education of what a normal period should look like, what bleeding should look like, what pain should look like, can be very helpful to patients to be able to truly examine the symptomatology that they're having and then say, actually, yeah, the stuff that you're saying that's not normal, that's me. Can we look into that?
Yeah, and then I think totally echo that there are just that way there's many different subtypes of recurrent pregnancy loss. There's many different subtypes of endometriosis, adenomyosis, and this is where that individualized patient assessment and care will come in. Are they symptomatic? Do they stand to benefit from debulking or fibroid or medical management prior to their next pregnancy? So I would kind of put fibroids in that same category. Not fibroids are common, miscarriage is common, they often overlap. A small percentage of patients with fibroids does it cause miscarriage, right? So how do I diagnose that? How big is the fibroid? Where is it? How are her periods impacted? And just again, weighing the pros and cons. Is surgery has a risk, but does it have a benefit to this patient? And what's my evidence of benefit for that individual person based on their risk profile, their symptoms, the severity of their disease? And another thing that in my practice, because I'm in the fertility clinic, that really I think differentiates some of my patients from others is, are they also experiencing infertility? Are they also experiencing all these other symptoms that we discussed? So it's a one-on-one, it's a one patient at a time discussion. There are medical therapies right now for shrinking adenomyosis and medically treating endometriosis that might be beneficial to a subset of patients, but the majority of people with endometriosis can go on to have a successful birth without any of that. So we want to look at, is the delay, is the side effects, is the risk of the treatment worth a potential benefit? And it really depends on all of those things that we have to put together.
Yeah, no, that makes a lot of sense. I mean, I have a couple more questions, but like, I mean, the summary is sort of like, hey, this is the baseline, and then beyond that, it really is about the individual. And so finding a doctor that's going to take that really good, fine look at your personal health history and think about what makes sense in the context. Um, I want to make sure I asked about this because when I kind of put out on social media, the biggest question I got was, well, why still is reproductive immunology not part of this? And a lot of people, I think, who are in that situation where I've done everything, or I feel like I've done everything, and I'm still losing pregnancies, where do I go next? Find themselves in that space. So I want to just open broadly and say, like, and I knowing that you actually an ASRM just did a whole podcast looking into this evidence gap and like kind of where current research is happening. Um, why isn't this ready for prime time?
Yeah, I think we're all looking for that answer. We have been fooled in the past, having been in this field of recurrent pregnancy loss for over a decade now. I've seen treatments come and go, right? Where we gave everybody steroids, and then we found out steroids don't really work. Then there was a big craze about, LIT or IVIG, and then these treatments, one ended up being banned by the FDA, and another just is very expensive and risky and has side effects. I'm just a little more cautious, right? That there is we really want to know that these treatments have benefit before we're rolling them out. And I call myself immune curious, meaning that I'm really following the literature and really looking for those clues of who might benefit from what treatments, because I don't think a blanket everybody needs treatment A or B is going to be the answer, right? We're really looking for better diagnostics of who does have an immune problem, and which treatment is needed in this particular scenario. Um, I think it's just not proven yet. And there are, just the same way, 50 to 80% of people will have a success without specific treatment. 50%, 50 to 80% will have a success with treatment. So it's very tempting to say, oh, my neighbor got success with this treatment. Maybe I will have success with that treatment. And that if after having repeated losses, you try something and you get a good outcome, you're going to attribute that success to that treatment. In reality, we have to have those controlled studies to know that that was higher success than people who didn't get the treatment. And it's so difficult when we don't have answers to um, really guide people through that really difficult decision, because obviously having a child is a very strong desire and very, very important, highest priority for a lot of people. And we want to support them in exploring options. But in terms of being able to recommend it based on the level of evidence we have, we're just not there yet. We need better studies. We need better identification of which patients benefit from the treatments and what is the mechanism. How can we link the treatment to the better outcome and know that we're doing something impactful with that treatment?
Mhm. Do you think then that people that are, using immunological therapy for RPL, do those physicians like have a responsibility to do this in a research context, or should people that are seeking out that treatment think about that? Like, oh, I want to find somebody that's actually conducting research on this. Like, I don't know, is there like a kind of a moral imperative for the community to like add to the body of knowledge? I don't know.
Yeah, I think everybody involved here is well-intentioned, right? That you can really see this both ways. I think that in order to protect our patients and the field, we really should not be guessing when we're giving treatments. We really should investigate what we're doing, why, how it's helping, how long does the treatment, what's the best dose of the treatment. And we're very fortunate. The US is not in a vacuum. There are other countries doing really good research in this area that we are learning from as we go. Certain the European networks have a very high success rate with these studies, and there is a pretty significant study right now going on right now about the immune therapies, and I hope it'll give us answers. But often these large studies gave us the answers that we don't need those treatments. So 600 recurrent pregnancy loss patients in Europe went through a randomized trial where half got Lovenox or blood thinner and half didn't, and the outcome was identical. 66% of people in both arms got a baby, to the point, right? So how can we really say that everybody needs blood thinner? So that was a pivotal moment where we said, okay, now maybe we don't want to do that. Let's look for something else. And so we really, in the service of trying to help patients, we don't want to settle on a treatment that only gives us a 66% success rate. We want to get better than that. So that's where the research is really needed, and finding those patients who have failed traditional, those 20% that didn't get their answers with that first line of investigation and treatment. So
Yeah, no, it's so interesting, and I have I have the, I don't know, benefit. I'm on like the other, I'm no longer trying to build my family, so I'm not in it as much, but it's like I definitely can, I empathize, because there was a point at which it was like, I will do anything. I will take anything. I will do anything.
yeah,
Like whatever you give me, I will do. Just get me a baby. But it is, you do then feel like over medicalized, and you feel like
yeah,
there's something that's wrong with you. And every month feels like an eternity. So I
yeah.
do also appreciate the like kind of reminder that, you know, less can sometimes be more. So I do appreciate that. I know we are at time, so I want to thank you both. I also want to, if you're willing to stay on for just a minute, there were questions that came in, but if anybody else has questions, now is really kind of the time to ask. I will ask a couple that came through. I think we touched on the reproductive immunology a bit. Um, so I'm going to ask this one, and I think you guys can see the questions too. 31 years old, living son conceived naturally, 4 consecutive losses subsequently, so secondary RPL. Um, First loss was a C-section scar and ectopic. I'll let you read that whole thing. I don't need to read it all, but is this sort of an appropriate situation for pivoting to IVF with PGTA, or is this something that you would manage differently? Knowing that this conversation is not medical advice. This is just a conversation, not directed medical advice towards you.
Yeah, 31 years old now.
Mhm.
I don't think there's evidence to support PGT if you're conceiving naturally. That you have an excellent, this person has an excellent prognosis for IVF and genetic testing. However, your chances of being successful without IVF is also extremely high. So at 31, with normal AMH and all normal testing, I'm assuming the rest of your uterus is normal, then success rate on your own is going to be in the 70% range. IVF with genetic testing will take you 3 to 6 months. The success rate per transfer is 50 to 60%. So you would have to kind of go further than that. Miscarriage is reduced but not eliminated with IVF. And therefore, if your baseline miscarriage risk is relatively low, you're medicalizing, like Megan mentioned, going through a lot of treatments to go from a miscarriage rate of about 30% maybe to a miscarriage rate of about 20% with IVF. So for some participants or people who are going through this, that's worth it. You want to do everything in your power to reduce that miscarriage risk. However, prognosis is so good without it. You're getting pregnant naturally without assistance that it's really a shared decision at that point. A lot of participants just really feel like they want to do everything in their power, and at least you've eliminated one cause of miscarriage that we know about, then we support you. On the other hand, if IVF is out of reach or just seems scary or seems like too much for you, I do trust that your body will have a successful pregnancy without it.
Even, can I ask a follow-up question to that? So even, I mean, assuming like, because I have people come to the support groups all the time, right? They've had 4 consecutive losses, and they're early 30s. Maybe none of them were tested. Had they been tested, like had a situation like this, all 4 losses had been aneuploidy, would that still be, kind of given age and everything, keep trying naturally? Or when should people think about pivoting to fertility treatments?
Yeah, it goes back to age, right? So this 31-year-old, thank you for sharing your story, by the way. had an explained loss. So that kind of absolves the uterus, right? The rest of you is fine. You had a baby, one of your losses we know was explained. The isthmocele loss, that was explained. So these are explanations that are random and based on your age, less likely to happen in your next pregnancy, even though you've had the same ultimate outcome in many times in a row. But if this person was 41 years old, I would say your chance of having another aneuploid loss is so high that I might push little harder or suggest a little stronger, consider the IVF option, especially if that ovarian reserve is high and you're going to have a lot of embryos to choose from. So you can, the age for me is really the pivotal thing, that the closer you get and past 40, the more the statistical benefit between trying naturally versus trying with the IVF you're going to see a bigger difference over 40.
The one thing I just didn't see in this story was like further evaluation of the cavity. I think that part of me is saying, well, I assume that there was some because there was a successful isthmocele repair, and so there probably was. But if that hadn't been done, that would be the other thing that I would think about here, because I wonder how that cavity looks after that isthmocele has been repaired. Is there another defect in the cavity? Is there something else in the cavity that's contributing to this? I'm not certain. That would just be the only thing I would want to also consider.
Yeah. Yeah. Look at that uterus. The endometritis testing is something to consider as well, because the more times you've instrumented, the higher the chance of introducing abnormal bacteria and dysbiosis. So I completely agree.
Then the last question, and then I because I want to be really respectful of time, but the last question in here is looks like somebody that has tried the entire gamut of immune therapies. I'm assuming also tried many of the prior standard treatments, and still not holding a pregnancy, but consistently getting pregnant on the first try. So if after sort of everything you're continuing to get pregnant, like no matter what, and just unable to sustain, where do people like this kind of go next? Or what's your hypothesis of what potentially was missed?
Yeah. I think, is this last one, AZ?
Yeah.
Well, don't give up. We're here for you. We have a community to support you. I think that, you just have to really look at everything else, right? What's the diabetes history? Have we screened for insulin resistance? Um, have we looked at the possibility of adeno or endometriosis? Again, rare, but if you've really exhausted all the other possible causes, those are things to consider. I
Male
also
factor?
Yeah, male factor. I also, I am a big proponent of high dose progesterone. I think that in selected cases, we do see benefit of starting progesterone in the luteal phase at, kind of this like what I call high dose, which is, either injectable progesterone or progesterone 400 milligrams twice a day vaginally. That is actually nature's immune modulator. So for people who are considering immune therapies, I would definitely exhaust progesterone first, because immune system is so complicated that you could push it the wrong way, right? There's so many factors, but we know progesterone is the hormone that is supposed to prepare your body for pregnancy and should be clicking all the right buttons in the immune system. So I use that fairly liberally in my practice, and then really try to go back to optimizing, once we've exhausted our list, preconception health, optimizing any exposures that you can, and really just like looking at if there is any subtle uterus factors that you want to look at. Um, and, very, very rarely, and this is really unproven, high order repeat miscarriage. Sometimes there are candidates for using a gestational carrier if we really suspect it's the uterus itself, but that is extremely rare in my practice. I would say maybe 1, maybe 2% of my patients do I go to that route.
Lathi, what kinds of
Yeah.
things make you, can you just expand a little bit more on what kinds of things make you want to have someone do a gestational carrier? When do patients start thinking about that? And what does that look like for them?
Yeah, I think, we have good um, tables on expectant management and what is the chances of having a successful live birth if you keep trying, right? And I really encourage, majority of people have greater than 50% chance, 50% chance or higher that they will be successful on their own. And often even better if we can optimize factors that we've identified. Um, but if we have repeated losses, 6 or more, if we have repeated euploid losses, 2 or more euploid losses in a row, if we have an identified uterine factor like severe adenomyosis or cervical insufficiency that's failed standard therapies like a cerclage has been failed, or it really has to be something where I'm really have ruled everything else out and still having unexplained losses, and that it really comes up with the higher orders. That being said, I've had patients with 10, 11, or 12 miscarriages that are unexplained have a baby. And I just want to give that hope out there that even if everything has failed, it's not zero, right? And so we have had patients, this year alone, we had someone who had 11 losses, failed donor egg, failed, IVF and genetic testing, and delivered a beautiful baby. So there's even when we can't explain things, I can't explain how that happened. I had, really started to get to a point where I didn't have much hope for that particular individual either. We were supporting her through considering other options, and she got pregnant. She had the courage to do it again, and sure enough, had a baby. So those are the people that keep us scratching our heads, like, well, we even tried everything ourselves, and here we are, but she's got her healthy, beautiful little baby now. So there's just so much that we don't understand. And, my patients and my practice have really inspired me to keep going and try to help the next group of people coming through. Whatever we can do, we'll keep at it. We're in it together.
Yeah. And I hold space also for the people that are, it is exhausting. It is emotionally
Yeah.
exhausting. It is physically exhausting. It is financially sometimes exhausting. And, if you need to take a break or you need to protect your health and move on to other options. I had a child via surrogacy. I knew I couldn't go through another loss. I was not in a place where I could handle that. So that is okay too. We all have to manage the next steps in a way that feels the most comfortable for us. So
Yep. Yep. Yep.
I,
Yeah.
we could keep talk. I could keep talking to you. I'm trying to like save your evening because I could keep talking to you about this for like another hour and a half. I did not even get through all my questions, and I think people keep submitting them. But I don't want to I don't want to keep you here for another hour and a
No.
half. Instead, I would just like to really sincerely thank you. Um, as I'm seeing the questions come in, I feel like what we need is just like a monthly Q&A where people can come with their like challenging situations and get input on it, because I think there are so few real experts like you, Dr. Lathi, that can kind of dive deep into some of these questions. Dr. Wyszewianski, thank you so much for your input as well, and particularly always remembering to bring it back to what is kind of the prognosis for long term, like health and long term and like later pregnancy, because once we leave a fertility doctor's office, like we want to get all the way to delivery, and sometimes that piece,
Yes.
we don't really think about it. We're so hyper focused on the beginning, we don't think about the end, and so I really appreciate like that regular reminder. So thank you.
And thank you everybody for being here and sharing your journeys and your questions. We're really inspired by you as well.
Any other closing thoughts, or otherwise we'll just thank you and thank everybody else. Please send us feedback if you liked this format, if this worked better than Instagram, what you'd maybe like to see in the future. Uh, Appreciate everybody's time.
Thank
Thanks.
you.
Thanks, everybody.
Thank you.